Here we go.
That's a great way to start. I don't know what you're laughing at, but it's hilarious. Good morning.
Good morning.
How nice to see you, Dr. Rosensweet. Thank you, thank you, thank you. We have our questions.
All right, I'm ready.
Cool. So I'm hoping you're well. I'm going to welcome everybody who's going to be coming up, and we will get started. So beautifully, we've welcomed in quite a few. Good morning, Rod. Quite a few new women. So I'm going to start with question number 1, and here we go. Dr. Rosensweet, I would really like a detailed explanation of the 24-hour urine test versus these other tests that I'm talking with my doctors about for measuring hormones. Why is the urine test better? I've asked other MDs and NDs, and they all say that blood, serum, 5-point are the golden standards of testing. And I'm trying to find papers in regards to this. I can't. I know you're the expert. Can you please explain?
Yes. Next question.
Right. Okay. So number 2. Oh, wait.
Wait.
We forgot number 1.
Oh, yes. Let's see. Blood testing is fabulous testing. My God, I've done so much blood testing over my career. I use it for so many things. And it doesn't work well for hormones, especially when we're treating a woman with hormones. It's very dependent on when the woman took her last dose, the dose that preceded the blood draw, and on something called pharmacokinetics, which is how quickly does, when she applies a hormone to her skin, does that hormone absorb and give a peak level? Applied to the skin, hormone levels rise. This is a peak level, and then it starts to decline. When do you test her? Are you testing her when she's at her peak? Are you testing her when she's on the rise to her peak levels? Are you testing her when she's over the top and is declining? When do you test her? Well, in order to know with precision where she is on that peak, you have to do something called a pharmacokinetic test, which means you'd have to draw her blood about every 15 minutes and plot out the levels and figure out when she was at her highest level, and then use that time interval to test that woman consistently.
Got it.
Serum tests are so challenging that 2 major organizations, the American College of, I think it's the American College of Endocrinology, that's hormones, but certainly the North American Menopause Society, have declared year upon year that do not test women in menopause that you're treating with hormones. That symptom relief is enough, and serum testing doesn't work, and they say certainly salivary testing does not work. That's their declaration.
Interesting.
They're saying, these are people who, do so much in the world of serum testing, and they're saying that when you're treating a woman with hormones, serum testing doesn't work. And I believe that I gave you one of the explanations. Now, having said that, I know really, healthcare providers that do use serum testing, and they do well with serum testing. I'm not trying to say it doesn't work at all, what do you test? Well, you can test the serum estradiol. You really don't want to test the serum estriol because it's so evanescent, meaning it comes and goes out of the serum so quickly. As you start testing the serum estrone, which you really don't want to do, you're starting to get into expense. I mean, you start doing blood tests, you're talking about major money.
Oh, yeah.
In the blood tests, we're not, as far as I know, capable of assessing the metabolites of the principal estrogens. And what metabolites are is when a hormone goes into your body, goes to the cells, does their thing, it's then biochemically transformed in the process of doing their thing into something called the metabolic byproducts. These are like, for example, estrone gets metabolically transformed in the process of being utilized into these metabolites, 2-hydroxy estrone, 16-alpha hydroxyestrone, 4-hydroxyestrone, and these get biochemically processed. This is the way the body does things. Are your heads spinning yet this morning? So serum testing is financially impractical, and because of the pharmacokinetics, in my opinion, it's not practical for each individual woman. Having said that, again, some people use serum testing. If serum testing was the only tool I had, I would definitely use it. I started out using salivary testing 25 years ago. It was brand new, and it was being touted as valuable. And it had some advantages to it. The laboratory could send the kit to the patient, and the patient could ship the finalized kit back to the laboratory. In other words, they didn't have to go get their blood drawn at a doctor's office or a laboratory. There were some advantages to saliva, and I was reasonably excited about it until I started comparing the salivary hormone test results with the patient and their symptoms. And there was such discrepancy between the results I was getting on the testing and what the patients had as far as symptoms were going,
right,
that I went, I don't know how to use this stuff. So I reached out to the very few colleagues that I had that were really doing this on a rather significant amount of time in their practice basis. In other words, they were acquiring some expertise, and they said, yeah, 24-hour urine hormone test. It's wonderful. It's been done since the 60s. It is the gold standard. And I started doing 24-hour urine hormone tests. And when I first looked at my first 24-hour urine hormone test report, I was sort of flabbergasted because there was like 20 different hormones and metabolites on that report. It was daunting, but I got it. Somehow in my guts, I got, yeah, the woman takes her hormones during the urine collection period, 24 hours. And we measure her while she's taking the hormones, and we see her hormone levels. And to my utter delight, just as my dear colleague, Dr. Wright, had suggested to me, the 24-hour urine hormone test correlated beautifully with the woman's symptoms. And I was sold. And it was daunting. I needed to call the lab and to get help with interpretation for about the first 50 to 100 tests until I got really familiar with the complexity of that test. And the more I got familiar with the complexity of that test, the more I realized why they chose so many analytes, because we would get the hormones plus the metabolites of the estrogens, progesterone, androgens, that's testosterone and DHEA, and the corticosteroids. There was a lot to look at there, but I eventually learned over time why you got so many of them. And one of the reasons I'm lingering there is this is why I think so many physicians have been reluctant to do the 24-hour urine hormone test, because it's a learning curve. In other words, you get to climb a mountain called, I've got a new thing to learn.
All right.
Well, like with my patients, geez, I think I won't.
Right. It's time consuming.
Now, the first significant 24-hour urine hormone test report, well, it was being done in the 60s, but there was an oncologist in the late 60s. His name was Henry Lemon. He was testing 24-hour urine hormone tests. He did a test on women who had breast cancer and women who didn't. And he compared the two. And he really added to our information. And so that's how long this is being done. And the other day I was talking to the laboratory director of the 24-hour urine hormone lab that we use. That's the only test he does, is testing hormones. Been doing it for over 20 years. He showed me the original research paper done by an expert in the field on 24-hour urine hormone testing, what it really took to evaluate hormones. It's rather staggering, the level of detail they do. And they're really describing what it takes to take the urine and run it through this high-tech machine called the GC mass spectrometry instrument, and get the great results that we get. Now, I don't even think I've come close to answering your question, but I do. But I have said serum, no, even by the North American Menopause Society statement, no. Saliva, no. People will debate me on this, but think about it. Saliva, is that a natural pathway that hormones travel? Well, under research conditions, there is a laboratory director that tells me that under research conditions you can do it and you can get some decent results, but not under the standard conditions of treating women in menopause. So blood, not ideal. Saliva, no, I'm going to lean towards that. And then there's some new kids on the block called spot urines. You urinate onto a filter paper, and these are analyzed. They're dried and they're analyzed. Well, there are a lot of problems with this.
I think this is addressing one of the questions that's up there.
Yeah, there's a lot of theoretical problems with this. For one thing, they report the amount of urine, hormones in the urine, in relationship to something called serum creatinine. They have to do that because they've got these individual filter paper samplings. And I'm not going to go into detail why they have to do that, but that creatinine is extremely variable, person to person. So to compare it against creatinine doesn't make sense to me. Just common sense, it doesn't make sense. One of the ways that that lab knows that there's trouble with that, and they're really trying to control this by specifying a very strict water intake and other parameters, directions, because you don't want to get variation in creatinine when you're comparing something to creatinine. You'd like to have something steady, yes. But it's very hard to control for that. And then inside information is they're having trouble extracting that from the filter paper. These steroid hormones are very gooey. They're oil soluble. They're fat soluble.
Yeah, they sink.
And so what the inside information is, this lab is having extraction troubles. But meanwhile, I feel so uncomfortable about that process that until someone actually shows me that there's a correlation with the 24-hour urine hormone test, even the owner of that lab, who's published 2 papers, I'm talking about one of the urine 5-point labs. That 5-point means they're doing collections at 5 different times in a 24-hour urine hormone, in a 24-hour cycle. What times are they choosing? Steroid hormones are pulsatile in their output. Well, at least when you're treating someone, they're not going to be pulsatile. But when are they choosing this? Did they choose it right after the application of one of the doses? Was it 2 hours after the dosage? Again, there's a pharmacokinetic issue, a timing issue. But you don't have that. You totally obliterate that timing issue when you're collecting all the urine for 24-hour urine for 24 hours. So the publisher, even of that, one of the owners of the laboratories has published 2 papers on the 5-point, and they even state in both times that the gold standard is 24-hour urine hormone testing. Why not do 24-hour urine hormone testing if it's the gold standard? Have I given you fabulous evidence? No, I haven't. But someone has got to demonstrate to me, because when I go in to try and figure this out, these glitches really are uncomfortable to me. And I'm getting, what's happening. We're playing in an area of testing women that costs them $300 minimal or more. And because scientifically, I personally cannot get at peace with the sampling methods, the filter paper, the trouble with steroid extraction from filter paper, how they get their sample, they punch out a circle from the filter paper, and the whole dried urine process, I cannot get comfortable with that. And then I have a dear friend and teaching partner for years that we used to teach annually at a very large conference, teach doctors and other health professionals how to treat women in menopause and men in andropause. He owns a laboratory. And because the amount of tests that they were running was diminished once the urine 5-point came on board, he decided to do and he's been testing, doing 24-hour urine since the 1980s. And he decided to try the urine 5-point himself in his laboratory to be able to offer that test. So we'd meet every year, and a couple years into him doing that test, I asked him, so how's it going with that urinary 5-point? He says, doesn't work for the ovarian steroids. To me, this was like talking to the horse himself.
Right. There's proof in that. Yeah.
And so when he himself didn't use it and he himself didn't trust it. So all that information, I know it's a shower of information, but that's why I personally choose the 24-hour urine hormone test. And having said that, my God, the correlation to actual women patients, and having done thousands of them, I have a tremendous amount of trust for it. And not only that, I've seen the consistency. So here's a question: does the 24-hour urine hormone test differ from a proprietary test? I don't know that the proprietary test that you're mentioning, I don't like to mention those. You say 24-hour urine? I don't think the proprietary test you're mentioning does a full 24-hour urine hormone collection. I think it samples 5 times during a 24-hour period. So you can correct me if I'm wrong, but I'm pretty certain about that. Bottom line, 24-hour urine hormone testing is fabulous. It works. I've had the chance to see the consistency because we test women every single year. And there's ways of looking at the analytes till you see, look at this. They're absolutely consistent. And I'm not going into the detail of how I can tell that. So I have a tremendous amount of trust for this. Summary, I love the 24-hour urine hormone test. I don't trust any of the others. They're not specific enough, or they're not accurate enough for my examination of these. So that's my opinion. There you go. You got an opinion.
We did indeed. And I've been getting that opinion for a long, long time. And I love that opinion. I really do. And I think it's always beautifully put. And I thank you for it very, very much. And I think that it's not the woman who I don't think it's the woman who made the question, but you answered it very well for this particular woman for sure. And I thank you for that. And I'll move on to question number 2, which is, and I think that this question comes from the insert that I put out, from what comes with the hormones. Anyway, it's up on the Ins and Outs of Menopause page, the too little, too high dosage thing. Which symptoms are attributed to low or high estriol or low or high estradiol? And how can you tell?
Yes. I think, I'd like to, I agree that this is probably coming out from a symptom card that we in the menopause method have given out for 15, 20 years, and 25 years, actually. This lists symptoms, and I don't know if you can see that card. It has symptoms of too little estrogen, too much estrogen, too little progesterone, too much progesterone, too little testosterone, too much testosterone. And most women who are entering perimenopause or menopause will recognize themselves through this symptom list of too little estrogen. For example, a woman who has too little has warm rushes, hot flashes, night sweats, temperature swings, sleep disturbance, racing mind at night, mental fogginess, weight gain, rapid heartbeat, dry vagina. It lists the symptoms of estrogen insufficiency. Now, do we bother to break that out into what are the symptoms of estradiol insufficiency or estriol insufficiency? No, I've never heard of that concept. For one thing, for a wide variety of reasons that we go into in the book, Happy Healthy Hormones, which you can download, we treat women as far as estrogens go with a combination of estrol and estradiol called biased.
Yes.
And this will produce 24-hour urine hormone testing profiles that replicate nature. We're trying to replicate what does nature do as far as the amount of estrol in a urine or the amount of estradiol in a urine. We just want to copy nature. As far as I know, it's never been broken out what an estriol deficiency is. And it's more an estrogen deficiency. And I just read you a list of what too little estrogen was like. Now, here's an interesting phenomena that confuses people. You can have hot flashes, warm rushes, night sweats from too much estrogen. So the most common thing that we encounter in the perimenopause and menopause is a woman who has too little estrogen. And I started to reel off those symptoms. And you can find those symptoms in the book. However, when we're treating a woman, if we give her too much of estrogens, she'll also have warm rushes, hot flashes, etc. And what I've always pictured is how that works is there's something in medicine called the pharmacological window. It's really ranges in which if you fall below that range, it's too little to have the effect. If you fall above that range, it doesn't work for other reasons. We've got to be treating women in the pharmacological window. This goes for anything, any medication, blood pressure medications. You got to hit the pharmacological window. There's a little range in there. Your dosages can be on the low end or on the high end, but there is that pharmacological window in which you will get the effect that we're looking for. But if you fall below, that's too little. If you go above, that's too much. Same with hormones. Too little hormones, you're going to continue to have symptoms of estrogen insufficiency, for example. But if you give too much estrogens, you go above the pharmacological window, the estrogen doesn't work well. How I picture that to be is we just flood the receptor sites with too much estrogen and you don't get the on-off phenomena. For example, if this is a hormone and this is a receptor site, how hormones work is they go into the receptor site, stimulate the receptor site, get the effect, then leave the receptor site, get metabolized and excreted. In, effect, out, or on, off. But if you got these you've got an overdose of the hormone by the chemical law of mass action. You can look that up, folks. You change the nature of the biochemical reaction and you don't get the on-off phenomena. Moral of the story is, if you don't give a woman enough hormones, she's going to have symptoms of insufficiency. If you give her too much estrogen, for example, she's going to have symptoms of insufficiency because the estrogen that you gave her is not going to do the on-off thing. It's not going to work. So that's why people get a little confused when they're looking at this card. They go, what the heck? You listed as a symptom of too little and you listed it as a symptom as too much? Yeah, it can be a symptom of too much. Moral of the story, read the book, and the job is always the same. If you're going to be treated with hormones, someone's going to have to write a prescription for you. And if you're going to be treated with hormones, your job is to go out and find someone you trust who's been well trained and is really taking this on as a special interest, if not a full specialization. And they're good at this stuff. They understand this stuff. They've been treating a lot of patients. They know what's going on when you bump into the challenges, which they can occur. Challenges can occur in treating women in menopause. Was there anything else to that?
No. I quickly wanted to say hello to Levon and to V and to Kathy and the other Kathy and Lee. And then I'm sorry, I know that Rod is here, and just acknowledge all you guys. It's so wonderful to hear from you, as I do every day, and have you here with us. You answered that really well, Dr. R. Thank you, as I think you always do. And I believe that I can move on to the next question, because I love the we can get into some interesting stuff with the receptors, and we will, but nevertheless, I will go ahead and I'll move on. I thank you for that answer. Moving on, it says, can you please advise us women who are over the age of 60 as to what is the best way to use hormones? I went through menopause at age 53. I was given testosterone. That's the only thing that I was given. I was not given estrogen due to the whole cancer fear. After watching the amazing Dr. R, and that's you, that's you, Dr. R, I am wondering if I made a mistake, and I'm now trying to make my way back. Thank you. I'm just now starting my hormone journey, and I'll take any tips you have.
I think it's really good news that you're restarting your hormone journey. It sounds like a restart. And my guess is that you got caught at a unique time in the history of treating women with hormones. And I'll get to that in just a minute. There is a phrase that you used in that question called, I went through menopause.
Yeah.
And I know what people are referring to there. There was a period of intense symptoms that you had, and then they disappeared, and thus I must be through menopause. Well, that's not true. In fact, some women, they never stop having symptoms. But there is common that some women have a period of intense symptoms, hot flashes, sleep disturbance, etc., and then those let up. And they make the statement, I'm through menopause. But the correction I'd like to make is no one is ever through menopause, and no male is ever through andropause. Here's why. All of us, men and women, our hormone levels are at the absolute maximum when we are 20 plus or minus a couple years. Maximum output from the ovaries, or as far as males goes, from the testicles. Then over the years, there's a gradual decline. These hormone levels, they get lower. So someone at 40 is not cruising on the same level of hormones that they had. Oops, I'm doing this backwards.
Mhm.
As they had when they were 20, high, 40, lower, and they keep on falling and they never stop declining. So when I test a woman who's 90 years old, some women have a little teeny trickle of hormones in there, just tiny, teeny tiny bit. And some women have zero when they're 90. But the decline starts when you're 20, plus or minus a couple of years, and it never stops. And there's heavy consequences of that decline because these hormones are so important for brain, for vagina, for bladder, for arteries, for the ability to think and not get compromise of cognitive function, for bones, for muscle. You never stop losing bone. You never stop losing muscle. So you're never through menopause. And if you look at, like I lived in Florida for 20 years and I used to walk the beaches frequently. And one of the things that surprised me is even though Florida is the home of many, many elderly people, I didn't see this vast number of elderly people on the beach walking the beach. And when I did, I saw it was very common to see extremely thin thighs in calves. Well, I was told about this in medical school, a story that I've told many times here, that we were getting a lecture from a gerontologist. This is an expert on aging, specialist on aging. And he said, let me tell you what's really going on with the elderly. You know, thousands of diagnoses, but here's what's happening to them. They're losing their muscle and they can't stand, walk, or walk with stability, and they fall on their osteoporotic bones, and they fracture that bone. And back in 1968, when I heard that lecture, that was the end. Hip fracture, it's all over. They died soon thereafter. Now the surgical techniques are so sophisticated that they can live for a little while longer. But really what he was describing, and he said it, he said, the elderly get sarcopenia and osteoporosis. And it's the sarcopenia that gets them into canes, walkers, and wheelchairs. That transition from walker to wheelchair is often coincident with the transition from living at home to going into an assisted living facility or a nursing home. Big deal. From sarcopenia. And there's also loss of muscle. That's what sarcopenia is, of the muscle that holds up the bladder. And when you put that together with vaginal atrophy from loss of estrogen, you get adult diapers. You lose control of your urine and you get adult diapers. Women are strong, so they always do what they need to do, but they don't like it. I can tell you from hearing a lot of stories. And they'd much prefer to stay at home. God bless the nursing home and the assisted living and all the workers that give so much to this very challenging job. But at the same time, one doctor and I, Dr. Berkson, who's very often joins us here. If you're out there, Lindsay, good morning. If you're out there, I don't know if you're there. We were discussing, like, what would be the effect on how many people had to go into nursing homes if people just got treated with hormones? The biggest drain on the Medicare and healthcare system is the end-of-life stuff that takes place in assisted living facilities and nursing homes. And so much of this could be totally avoided by treatment with hormones. Oh my God. Sarcopenia, loss of testosterone. Testosterone is not a male hormone. Testosterone is a human hormone. In women, you need it as much as men do. Different amounts, but in order to preserve your muscles, you need testosterone. You need your androgens. You need DHEA as well. So let's see where to go with this.
Well, I want to ask you something because you're going along fine.
Yes, I remember too. Sorry, go ahead.
If I can ask this, we've discussed this quite a bit before, and I've never really quite understood this term, post-menopausal.
It's not accurate, because the most significant thing going in menopause or andropause for men is the decline of the hormones, and the decline never stops.
Right.
And the losses of function of muscles, of bones, of arteries, of brain, plus, that continues, that marches on. Why there is a term called postmenopause is that a certain percentage of women who get into the perimenopause and the early menopause, they have some raucous symptoms. Hot flashes, night sweats, they can't sleep, cognitive decline. It's a screamer, and it's a life stopper or a life slower downer for many, many women. A certain percentage of those women who have these raucous symptoms, these symptoms quiet down after a year or two or three. And that's where the term postmenopause came in. It only refers to those women who are unlucky enough to get the decline of symptoms. Or the most unlucky, from my standpoint, is the women who they don't have any symptoms. About 25% of women stop having periods, but they don't have symptoms. So they go, what in the heck's going on? I wonder if everybody complaining about menopause. My period stopped. I like that. But I just said the ones I feel most concerned about are the ones who don't have symptoms. I feel second most concerned about the women who are in the, quote, postmenopause. They've stopped having symptoms. And the ones that I feel are the safest are the women who are going ballistic with the symptoms. Because these women are motivated. They want relief, and they're going to do the heavy lifting to seek out someone who can assist them with replenishing these hormones. Absolutely. I know it's a funny way of looking things, but just think about it. It's those very symptoms that drive women to the solution.
Oh my God, you have to. Well, as far as I'm concerned.
So now let me go to another issue, because she's 60 years old, and it sounds to me like when she started taking hormones, the great fear of the devil came in, because the devil had come in to our world. Because women have been treated with hormones. Their hormones have been replenished for 1,000 years. Not the majority of women, but boy, in the 1950s, with the pharmaceutical industry producing Premarin and Prempro, these are horse urine-derived estrogens, and Prempro is something where you combine that horse urine, pregnant mare urine, Premarin, the estrogens in there, with an artificial progesterone. We don't call it progesterone, we call it Progestin, because it's such a different molecule and a problematic one. But boy, from the 60s, 70s, 80s, there were millions of American women. By the early 2000s, 40% of American women were being treated with Premarin and Prempro. Just had an odd sound in my house here. Excuse me.
It's the ghost.
Uh-oh.
Oh.
I mentioned the devil, and the devil is stirring up.
That's creepy.
Excuse me. So 40% of American women who were in menopause were being treated with Premarin and Prempro in the early 2000s. It was the most popular and profitable drugs of all time. And in 2002, as so many of you heard so many times on this particular Facebook Live, the study came out that falsely reported increased risk. Even in the study itself, it said there was less risk for women who were taking Premarin and that there was a small and statistically insignificant risk for women on Primpro. Well, in the world of science, when you see the word statistically insignificant, you know there's no significance of all, and they never should have reported that study. And there was a lot of opposition to reporting that study, but it leaked out and it got out and it was published. And it scared women in the United States and worldwide and healthcare providers because there was an increased risk. The part that got blasted out into public circulation was there's an increased risk of breast cancer if you take hormones. Statistically insignificant. I saw that. I went, well, I know what statistical insignificant means. It means there is no increased risk.
Right.
Even that study committee, they followed these women. They stopped the study, but they followed these women. And by 2006, they saw that there was no increased risk in these women. And by 2017, the same study committee issued a retraction in which they said, after 18 years of follow-up, there is no increased risk of breast cancer, heart attack, and stroke. Well, so many women and healthcare providers heard of the increased risk that was falsely reported, and so many folks have not heard about this 2017 paper published by the same study committee in the same journal. Who's heard of this? Very, very few people have heard of this. And this woman who's 60 got trapped because if we do the math, and she's 60, when she was in perimenopause at 40, I'm making some guesses here, oh my God, that's when that Women's Health Initiative study came out. So she was given only testosterone because everyone was terrified of estrogen, healthcare providers.
Right.
And it was messy. And it doesn't, yes, okay, great. Replenish testosterone. Every single human being needs to have their testosterone replenished. That's great. But it is not going to it's not going to carry the day. Women have got diminished estrogens and diminished progesterone. And you need more than testosterone. You need the estrogens and you need the progesterone as well. And then you probably didn't get the greatest results. So for whatever reason, you stopped. But here's what I'd like to say. You're back in the saddle. Congratulations. I will take my hormones every day that I'm privileged to stay on this earth. And women, that's my best recommendation to you. Because even though there was falsely reported risk to taking hormones, and the medical literature tells us that there is no increased risk, there's a near certainty of major troubles in men and women if you do not be treated with hormones.
Right.
There's almost everyone's going to lose bone strength, osteoporosis, risk for fracture very high, lose muscles, canes, walkers, wheelchair. And when you couple that loss of muscle with the vaginal atrophy and the loss of the muscle that holds up the bladder, adult diapers, not to mention that you go back into increased risk for arteriosclerosis and cognitive decline and skin and libido and hair, and it goes on and on and on. These hormones are the most powerful chemicals in our body. They're very influential in so many different ways. Mood, sleep, oh my God. So I say the best thing is you're back in the saddle, and I hope you are fortunate enough to connect up with someone who really knows what they're doing, and they're going to adjust you in, dial you in, and then for the rest of your life, hopefully you'll get dialed in and periodically followed annually, and take them my recommendation is take them for your whole life. Are we at risk for cancer? Are we at risk for 1,000 diagnoses? Oh God, there's so many diagnoses I'm at risk for. And then are we at risk for cancer? Yeah, we're at risk for a lot of cancers. And as a male, I'm at special risk for prostate cancer. And there's reasons why that's so. And as a female, women are at increased risk for breast cancer, ovarian cancer, and uterine cancer, cervical cancer. There's reasons for that. However, women who are treated with hormones are at less risk for breast cancer, heart attack, and stroke than women who go untreated. And the best data is women who are on horse urine-derived estrogens. And not that I've ever written a prescription for that in my life, nor would I, because I feel like the field is advanced so wonderfully beyond using horses. We got same molecule stuff, bioidentical stuff. And that's the only thing I've been prescribing for 25 years. And men are at less risk for prostate cancer if they're treated with testosterone. So, good going. Get it dialed in. Glad you're back in the saddle.
Me too.
Sometimes
Absolutely.
when a woman has been 10 years into menopause with no hormones, and I wasn't quite able to extract the clarity on what this particular questioner had. Sometimes we want to do a special cardiovascular evaluation because arteries that don't have the advantage of estrogens for 20 years, a few of these women or some of these women can be at risk for arteriosclerosis and a clot, etc. But that's very esoteric information to be sorted out by your healthcare provider. But if you've been 10 years, the remedy is get a stress echocardiogram to see if there is any possible clot in a coronary artery. We do that from time to time when there's been 10 years without any hormones at all. There we go.
Interesting. Very interesting. Okay, well, thank you very, very much for that. A question came up, and I want to get to these other questions, but I think that you can answer this quickly. Is progesterone micronized progestin?
No. Absolutely right. No.
Right.
Progesterone is best case scenario, and especially when it's micronized, a molecule that's identical that the ovaries used to produce. That's progesterone, and when you see the word micronized, you can be pretty much assured that that is a bioidentical progesterone, identical to that which the ovary produce. Progestin is a synthesized molecule that's so different from progesterone, but it has some effects of progesterone, but it's a problematic molecule. And anyone who wants to see how problematic it is, please look up the works of Phyllis Bronson, a PhD, who studied and reported on progestins and the problems of progestins. But they do suppress the uterine lining, and they were developed because patented hormones or hormone-like substances, someone can make a significant profit off of that, but you can't patent natural molecules that are present in the human body. In the medical literature, there is universal confusion. So often when the word progesterone is used in the medical literature, they're not referring to progesterone alone at all. They're referring to a progestin molecule, which is a different molecule than micronized bioidentical progesterone. They do it all the time. Or they'll use the word progestins as if they're covering all progesterone in a woman. They'll say a woman's progestins. Well, a woman doesn't have any progestins. There's no such thing. She's never produced a progestin in her entire life, nor will she ever. Yeah. But that's really when you approach the medical literature. But I think it's very important, especially for professionals, to know the difference between progesterone, a natural molecule that's produced by the human female ovary, and progestins, which are an artificial synthesized molecule that, if it wasn't so problematic, I wouldn't be raising a fuss about it. But
so
if the only tool I had was progestins, I'm about to let this come out of my mouth, but it is true. If the only tool I had for a woman in menopause was Prempro, I would use it. And we're a big tent. We want women to have access to the whole panoply of how they're being treated, because a lot of women were on Prempro and Premarin, like millions, 18 million to be specific, in 2002, and it did so much good. So we're not in opposition to anybody. If the insurance pays for it, and if the only access that you have is to Premarin and Prempro, bless your heart, you're going to do so much better than women who go untreated in a lot of different ways. So we're a big tent. Although I'm a strong advocate for compounded bioidentical hormones, I say all of these hormones, when administered with someone who knows what they're doing, they all do good. And women who are treated with any of these hormones, if they're treated decently, not overdosed, not underdosed, you're going to get a lot of good out of them. The only thing about Premarin and Prempro is things had not risen to the level of also including testosterone.
Right.
So the women who took Premarin and Prempro, bless their hearts, they did much better than their non-treated compatriots. But the field hadn't advanced to where they saw the crucial, absolute necessity of replenishing testosterone as well. So Premarin and Prempro did not have the androgens, did not have testosterone. That's a big deal. But still, women who were treated with Prempro did so much better than their non-treated colleagues, compatriots.
Cool. Thank you for that. I think that you've probably made her feel a lot better. That's for
And one
sure.
thing I'd like to say about micronized progesterone is that's what you want. And topical progesterone that's compounded by pharmacists is micronized. And also, you can swallow progesterone, unlike estrogens and testosterone, which it's far from optimal to swallow estrogens, and you should never be taking oral androgens. I don't even think you can get them, oral testosterone. But progesterone is good to take orally, and sometimes it has special sleep advantages and mood advantages. So third of my patients are on oral progesterone, and what you order from the pharmacy is oral micronized progesterone, anywhere from 25 milligrams to 225 milligrams. And we have women determine their own dose. So micronized progesterone, bravo. Progestin, not in this day and age. If it was the only thing we had access to, okay, progestin, but we don't. We've got access to molecular copies identical to what's in a human female body. So I always have, I've never chosen a progestin. I always choose micronized progesterone when I'm dealing with progesterone.
Beautiful. Thank you for that. So I'm going to go way over to a different side of things here with a question that came up that I think is really interesting. And this questioner says, if a woman has sluggish, low, and slow lymph flow, try saying that 10 times fast, it's not easy, would this affect one's ability to absorb bioidentical hormones topically?
Well, I've never encountered this to be an issue, as I've never seen a patient that's had the diagnosis of sluggish lymph flow, except when lymph nodes have been removed and then an arm swells up and the lymph flow is absolutely compromised.
Yeah.
That's for sure. However, compounded bioidentical hormones that are applied topically, or hormones that are applied topically, are absorbed into the subcutaneous fat and picked up in the venules. So it goes right into the bloodstream. So it's not a lymph thing. Topical bioidentical hormones do not rely on the lymphatic system for absorption.
Okay.
They rely on the bloodstream. So no, the answer is sluggish lymph flow should not be a problem. Of course, these things, you always figure it out patient by patient. I'm giving you a theory. You should not have a problem. But in the hands of someone who really knows what they're doing, they should be able to figure out a way for you to take hormones, even if we use alternative methods, because you never say never in medicine. I only treated one patient in my entire life with oral estradiol, a lot because it's not the optimal way to do it. But geez, just 5 minutes ago, I'm saying, hey, listen, if the only thing you had was Prempro, I would have prescribed that. That's oral estrogens plus progestin. So you never say never. There was only one patient I ever treated with oral estradiol, and it was my own mom because she had compliance issues. She could swallow a pill, but she couldn't apply things topically. She couldn't figure it out. So you never say never. So if there were an issue related to lymph flow, we would find it out. For one thing, you'd be treated with hormones and you wouldn't be getting the results. Or when we went to, you wouldn't be getting symptom alleviation. That would be the way we test you. We would give you topical bias, topical progesterone, maybe oral progesterone, topical testosterone and DHEA, maybe oral DHEA. And we'd see if symptoms were alleviated, if you had symptoms. And if you weren't, we'd wonder what's going on here. And we would figure workarounds, even if it went so far as to take oral estrogens. Oral progesterone, no problem. Oral DHEA, no problem. Testosterone, not okay to do oral testosterone, but we'd give it to you intravaginally and or in your external perianal mucosa, and you'd absorb it. Well, I can't imagine with a lymphatic issue that you'd have trouble with hormones, but I want to cover all ground there. And that's why I'm saying there's usually a way. I was about to say always a way.
I know how careful you are with your wording, for sure. I am seeing these questions. I will get to them, as you know. I always do. Thank you, Levon, for yours. I'm going to get to my last question here because we're getting close to that bewitching hour. The questioner says, I'm 50, now going into 6 months without menstruating. When I went to my doctor, he did not do a pap smear. He only felt for my ovaries, but oddly couldn't find them, though I am having horrible ovarian pain. I'm wondering, Dr. Rosensweet, if you recommend a pap smear 6 months into not having a period, and I thank you very much. Would it be recommended to have a pap smear 6 months into what I'm thinking is possibly perimenopause, but I'm not sure. I'm not the doctor.
Well, pap smear is an issue. It's an easy screening test to pick up on cervical cancer. Cancer of the uterine cervix. That's the part that protrudes into the top of the vagina. It's not a super common illness, but gosh, it's a wonderful thing to detect a cervical cancer in an early stage because the treatment is almost universally 100% cure. Such a simple screening procedure. Just rub a plastic stick or a swab on the cervix on a routine pelvic exam and look at it under a microscope by an expert. And you can see the first cellular changes of a cervical cancer. Well, I think that's a just breakthrough test. Now, I leave this up to the gynecologist. They have specific guidelines on when to do pap smears, how frequently to do them, what the indications for that is. And yes, we care about what the gynecologists are defining here. And one can make a case for having a professional guidance from a gynecologist for every woman. Now, as far as not feeling the ovaries, I did pelvic exams for 35 years. And I'd say half the times, and even though I have large hands, I've got a size 8 glove in surgery. This is a big hand. That means my fingers are long. I couldn't feel 2/3 of the ovaries. They're up there. And you can't necessarily reach them. So I'm not going to call that abnormal in any way, that the provider could not feel the ovaries and reported that. I cannot feel your ovaries. That's not a sign of illness or any ovarian problem whatsoever in my book. Pelvic exam does not allow only the longest fingers amongst us to feel the ovaries, to feel the actual ovaries. Now, when there's a suspicion of ovarian problems, there's other ways to diagnose that. For example, a pelvic ultrasound or transvaginal ultrasound gets a real good view of the ovaries, including cystic ovaries or even ovaries that could have a cancer in there. So gynecologists, once again, this is their home territory. And if you got a gynecologist that tells you I cannot feel your ovaries, you ask the gynecologist, is that a bad thing? I can't help but think that they'd say, no, it's not a bad thing. It's not a deal whatsoever. But with the symptoms you're having, I think we should get a transvaginal ultrasound to look at your ovaries, stuff like that. And they're capable of doing that right there in their office. So don't be discouraged that your ovaries could not be felt. But the bottom line is, gynecologists are important, dermatologists are important. These routine screening tests that we can get to prevent common cancers, they're really important. Yeah, we can get away with it sometimes, but not all the times. You pick up a skin cancer, or you pick up a cervical cancer early on, man, you pick up a breast cancer early on, you got a chance of 100% treatment. That's why we are strong advocates of mammograms, of dermatology exams, of dentists, going to your dentist frequently.
That's going to come up next interview, the mouth.
And, it's time for me to say hasta luego.
Hasta luego.
Until Thursday.
Au revoir. À tout à l'heure. Okay. Well, ladies, thank you so much. Dr. R, always thank you so much. And I'm going to get the question. Well, I have my questions after Thursday. I'm going to add some in and do some tweaking here and there. And we will see you again on Thursday.
Excellent, Carolyn. Always a pleasure.
Always a pleasure.
Bye-bye.
Bye, everybody. Enjoy.